I'll explain that in just a moment. I think the best way, though, to view the webinar today is in speaker view. So in the upper right-hand corner, you'll be able to click the view button and then select speaker view, and that'll give you a nice side-by-side of Dr. Chandwani and his PowerPoint. So thank you, everyone, of course, for joining us this evening. I see a lot of familiar faces and a lot of new ones, so that's always exciting to see a great mixture. We do these webinars every single month, so if you ever have any webinars or any topics that you'd like us to discuss, always feel free to put those in the question and answer box, and we can see about addressing those and tailoring them to a future topic. So our webinar topic this evening, what we'll be discussing is tailoring your occlusal appliance for TMJ disorders. So we'll break about halfway through to answer some questions, and then we'll answer questions again at the end. So there'll be a couple times to ask questions. If you utilize that question and answer box as you have them, just go ahead and type out your questions there in that question and answer box in the bottom, and then we'll address those on those couple breaks. We'll also have a live promo code for all of you that stick around to the end, so make sure you stay, and we'll address that at the end. Now I'm going to pass it over to Frank to talk a little bit about True Function for those new faces on here before we get started.
Thank you, Trish. Hello, everyone. Welcome. Welcome. Thank you for joining us tonight. For those of you who are not familiar with us, my name is Frank Madrigal, and I'm the founder of True Function. Started True Function in 1999 with a single mission, as it was to become the trusted partner for oral devices and related products for our clinicians, the clinicians that we serve. What sets us apart is our relentless focus on innovation, our quality products, and our ability to provide expert technical support to our clinicians. We are today, again, I want to thank Dr. Chandwani for joining us, for sharing your expertise with our group. And I want to thank everyone who's taking your evening. You know, I know your time is valuable. You probably had a long day of seeing patients, and yet you're making the time to join us and to learn along with us. So we look forward to having you. Again, Dr. Chandwani, we appreciate you. We value your time and your expertise, and we're very grateful for you being here. Everyone, we look forward to this great presentation, and again, thank you for joining us.
Thank you, Frank.
All righty. I would like to introduce one of my favorite people and a dear friend of ours here at True Function, Dr. Chandwani. Dr. Chandwani is a residency-trained oral facial pain and TMJ specialist who specializes in complex facial pain conditions, including TMJ disorders, trismus, jaw spasms, trigeminal neuralgia, atypical facial pain, trigeminal nerve injuries, neuropathic pain, and headache disorders. Additionally, Dr. Chandwani is a licensed acupuncturist and often incorporates acupuncture, supplements, and natural remedies as a first step in treatment if possible. Dr. Chandwani's philosophy focuses on precision diagnosis and understanding the underlying mechanisms and complicating factors. Dr. Chandwani has extensive training and more than 15 years experience in modalities such as nerve blocks, trigger point injections, prolotherapy, TMJ injections, occlusal orthotics, and other mouth guards. Dr. Chandwani has authored numerous scientific articles in peer-reviewed journals and is an invited reviewer for the Journal of American Dental Association and the Annuals of Otology, Rhinology, and Laryngology. He teaches oral facial pain and sleep medicine to postgraduate residency programs in dental schools. Additionally, he has lectured nationally and internationally on various topics of oral facial pain. So thank you for joining us this evening. As always, I'll pass it over to you to get started here on the webinar.
Thank you, Trish. All right.
You're welcome.
I'm hoping I'll see you all who are listening in at the American Academy of Orofacial Pain in Virginia, which is coming up in about a month. Okay. All right. So orofacial pain, temporomandibular disorders. It's I was kind of listening to the news, and it sounds almost like our tariffs right now. Very vague, very complex. We really don't know what's going on. So a good analogy, if you think of temporomandibular disorders, could be with the current tariffs. Okay. No rhyme or reason a lot of times, but we'll try to make sense of it regardless. I mean the temporomandibular disorders, not tariffs. you could kind of think of the diagnosis as a top-down approach. So when you're evaluating a patient, think of how much is a central involvement, central being brain, central being autoimmune system, central being lifestyle. So those are kind of more top-down thought processes. And then you got to think of more bottoms up, like is somebody has severe bruxism, somebody has inflammatory disorder of the joint, just muscle cramp. Those would be more peripheral problems in kind of from a diagnostic mechanism. And the majority of them will have kind of both to some extent. So you've got to figure out is it predominantly a top-down diagnosis or a predominantly bottom-up diagnosis? Okay. And that's important because it will really give you a sense of uh, how conservative to be, what kind of treatment modality to use. So knowing the William Osler said this, knowing the patient is a lot of times a lot more important than knowing the disorder or disease. Okay. Uh, kind of temporomandibular disorders versus orofacial pain. Orofacial pain is a lot more encompassing. So I'll try to use that word because that's definitely more appropriate. Okay. Slides need to go forward. All right. When you kind of think of treatment, again, you could think of top down or bottom up. And now this is more dependent on the patient rather than the diagnosis. So uh, mind body, I'm a big believer in mind body medicine, and it could be manipulative or psychotherapy, behavioral therapy. There's definitely a lot more kind of data for something like that compared to the bottom ups intervention, physical medicine. It could be physical therapy, occlusal appliances, trigger point injections. But the lack of data doesn't mean a lack of efficacy. So uh, and I'll hone in on oral appliances. That's kind of my focus. Okay, this is a cheat sheet that kind of I use in my practice. If somebody has orofacial pain, if they have kind of jaw locking, snoring, maybe an repositioning appliance, all this is maybe. If it's more muscle pain, maybe a stabilization appliance, but then you could always mix and match. Uh, if you need, I think we'll have recording of this presentation, but if you need slides, just email me and I'm happy to share my slides. Okay. So this tends to be my starting point, not the end point. Usually this is how I start thinking, and we'll kind of talk about uh, if somebody is a good candidate for oral appliance, we'll say, why do we do oral appliances? Okay, and mechanism wise, it alters joint mechanics. Initially, a few years ago, we used to say it reduces joint stress, but there's not one study which shows that it really reduces joint stress. Philosophically, you can argue this, but at least with regards to kind of data. Uh, we don't know exactly where there's increased stress and which needs to be reduced. So alteration in joint mechanics is more a reasonable kind of mechanism that we could argue that it does. It's a great biobehavioral appliance, habit breaking, and it could be nighttime or daytime. It's definitely an elegant placebo, and there's nothing wrong with using an elegant placebo. And then, of course, at times, if it's an acute process, you put in an appliance that could be a regression to mean, so might not be an active treatment. And this kind of was one of the first oral appliance that was used. I think it's like 60 or 100 years ago for sleep disorders. Okay, so really a lot of data. But then if you look at neuromodulation, you can really modulate pain by physical, chemical, magnetic interference, light therapy, ultrasound. You can really downregulate pain via multiple mechanisms, and an oral appliance could be just one of those. Interestingly, there's a couple of fMRI studies showing that with oral appliances, you can really change blood flow to certain areas of the brain. Some decent data to show that they do kind of alter pain. Okay. Uh, all right. Now let's talk about specific disorders. Bruxism. Okay. There's poor data that an oral appliance. Okay. And this is a very kind of conflicting thought process. Okay, there's very poor data that they are effective against bruxism, that they stop bruxism. Do I use it all the time? Yes. So stopping bruxism is different than stopping the problems associated with bruxism, being pain, fracturing teeth, poor sleep. Okay, so appliances are really good at addressing those. But if you talk about stopping bruxism, data shows that really there's a very small subset of people where they stop grinding their teeth with use of oral appliance. But then if you look at other interventions, psychotherapy, physical medicine, drugs, their efficacy is poorer than an oral appliance. So it's not as if there's anything better than an oral appliance. Okay. And a lot of patients, there's actually a couple of studies which show that if you put in an oral appliance for about 2 to 3 weeks initially, a lot of patients do stop clenching, grinding, and then the central nervous system again goes back. So just because somebody says they are feeling better, it may not sustain. And that's okay. Educating the patient that we're not really targeting the behavior, we are targeting really quality of life. That's the goal of oral appliances. Okay. What about temporomandibular disorders? Okay, short-term and long-term effect. Not great, especially in the long-term effect compared to other modalities, but short-term for 4 to 12 weeks, they're definitely very good. Okay, as you could see in this, I know the slide is a little bit too busy, but at the same time, you could see stabilization. A lot of these studies, the dot is beyond this white line, the solid line. The studies which were negative for oral appliance are on the left side of of that line. 1, 2, 3, 4, 5. There's like 5, 6 studies which were where the appliance was not more beneficial than just control group, but there's a good 10, 15 studies showing that short term there's efficacy. Okay. What about internal derangement? Disc displacement without reduction. Okay. Uh, this was kind of a really decent study where patients were given a stabilization splint, anterior repositioning splint, a MORA or the mandibular occlusal repositioning appliance. And they found that most patients, regardless of the appliance, had reduced pain, reduced noise at 6 months. Group 2, which is really this middle appliance, had the best kind of comfort. Uh, but overall, no kind of significant difference between the groups. Okay. So, and there's number of studies looking at different designs. Data shows that one design is no better than the other. You could use a mandibular appliance, maxillary appliance. If you look at 100 patients, a large population, 100, 200 patients, you will find 60, 70% of patients do well regardless of the design. So these work quite well if even if you don't tailor your appliance or kind of you don't kind of phenotype the design. But I would argue you can really increase your kind of success or efficacy by making small kind of changes in your design appliance selection And I think you can increase your efficacy to close to 80, 90% from like 60, 70%, well, good 20, 25%. So, and how would you do that? It changes kind of adherence, compliance. There's definitely some value in improving efficacy, improving comfort. And then the biggest thing is reducing side effects. Okay. Uh, this is where I always start. I always ask patient, did you ever have an oral appliance? Okay. If somebody tells me they've had an appliance for like 20 years and they love their appliance, I'm replicating that design no matter what. Okay. So that's a no-brainer. But if somebody had an appliance and they didn't tolerate a hard appliance, they didn't tolerate a soft appliance, then I can explain to them that if they used a soft appliance, maybe they were clenching or grinding on it like a chewing gum. There's definitely a small subset of patients who kind of don't do well with soft appliance. Not a lot of people, but definitely in my experience, there is a subset of people who just get worse with a soft appliance. Uh, Even with hard appliance, there's a subset which gets worse, and that intolerance could be because of the appliance being too tight. That's been my biggest thing. An appliance which is wedging in the interdental area, uh, it becomes a lot easier if they have their old appliance, so you can kind of almost compare it. Uh, but then there's patients who say they had side effects. They had gagging sensation, occlusal changes, mucosal irritation. I had a patient a few weeks ago, and she said, I put in an appliance, my tongue she almost develops a tongue thrusting habit. And I actually just added a kind of a anterior ramp, which was non-functional. So it was really to push the tongue back, and she started tolerating an appliance. So very interesting kind of, if you ask the patient, they'll tell you really, give you clues as to which design they would prefer. Okay. So this is probably the most conservative occlusal appliance. If it's a young patient, and usually, if they've finished growth, so 16 to 20-year-old, the bone is definitely very flexible, malleable. They can have occlusal changes really fast. So try to do something which is really forgiving. Okay. And SX is probably my favorite appliance, but at times I do a SX with a Holly. Uh, Number of conservative options. I always find a thicker SX tends to work a little better, 1 millimeter, 1.5 millimeter. Uh, so what about muscle pain? Okay. Somebody who has muscle pain, I kind of they could have if they have poor sleep or they're waking up with pain. This is kind of the design I pick, a flat plane stabilization appliance. I don't necessarily need contacts all throughout. As if I have like about two good contacts on either side, I'm happy. If I have two good contacts on this posteriors and a couple of contacts on the anteriors, I'm still happy. So as far as there's no occlusal shifts, the number of contacts, especially in the first 6 to 8 weeks, I'm not concerned. Long term, I like to have more contacts. Uh, so this is kind of my go-to appliance for kind of uh, a muscle disorder. And uh, I'll have kind of more tips on if it's a muscle disorder, how to pick a upper appliance versus a lower appliance. Okay. So if somebody is sleeping poorly, okay, and their symptoms get worse throughout the day, maybe they need a stabilization nighttime appliance, maybe they need a daytime parafunctional appliance, which they use a couple of hours during the day, not all day. And today I had a patient who who said she wakes up with no symptoms. As the day goes on, she starts kind of, she just feels her jaw is just off. So no, it doesn't have pain. So I asked her, do you work from home? She said, yeah, 2 to 3 days in a week I work from home. I'm like, Cameron, do me a favor, use your nighttime appliance for 2 to 3 hours during the day, and let's see how things go. A lot of times, the daytime appliance, you don't necessarily need it for too long of a duration. So 2 to 3 hours for maybe a month. And if they're working remotely or they're working kind of in a quiet office, often I just ask them to wear their nighttime appliance for those 3 hours. And it doesn't have to be 2 to 3 hours at a stretch. I tell them this is like physical therapy. You don't do physical therapy in your kind of arm when you are lifting. You do physical therapy when it's convenient. And the idea is it will change your behavior. It will kind of make the muscles, the joint more resilient. That's the goal of kind of oral appliance. Uh, what about a patient who has muscle pain, has morning headaches? Okay. Now it's a little bit more cumbersome design. I use a disoccluding appliance for like 2 to 6 weeks. And after 6 weeks, I either alter the disoccluding appliance to a stabilization appliance, but most commonly, I actually give them two appliances, a disoccluding and a stabilization appliance. And the disoccluding appliance is really depending on the symptoms, they're using it as needed. So this is my common protocol on patients who have morning headaches, but I tweak it according to their kind of response, according to the outlook. So, and it gets a little expensive, but I think I really see good outcomes using kind of this protocol. Uh, uh, Internal derangement. So I often take a bite, even if it's a muscle disorder. I think if you take a bite, it just makes your chair time seamless. Uh, I would say 75-80% of the times, I put in an appliance, and the appliance is just balanced when I send a bite. So I may have to make it a tiny bit more loose, but it's literally about 3 minutes. I'm done delivering this appliance compared to if I don't send a bite, I could be adjusting the appliance for 15, 20, 30 minutes. Uh, so I often take a bite in the position I need. So if it's an internal derangement case, I find a position where the clicking is reduced, or maybe the locking is reduced, and I send that bite. Sometimes I use bite registration, but at times I use thermoplastic resin. I find that it's also kind of easy, and you can use a small thermoplastic resin, especially if the mouth opening is limited compared to a bite registration. And depending on the jaw record, okay, most of my internal derangement patients, okay, and Frank will tell this to you that I do give him a headache because half of my patient, I have a repositioning ramp just like this. And the other half, I have patients where it's an appliance like this, okay, a kind of anteriorly is nothing. And in a lot of other patients, I have uh, only the lower arch of the dorsal fin appliance. Okay, so just because their tongue is too large or their maxillary arch is really small, then I'm using a mandibular appliance to kind of get the repositioning mechanism. Before we actually, let's talk about tongue. So tongue is really important. If they're kind of, if somebody has a large tongue, I try to give tongue a lot more space. If they have scalloped tongue, often I kind of use a disoccluding appliance for like 4 to 6 weeks. If they have coated tongue, I really try to keep the palate extremely kind of non-existent. So open palate, almost nothing is touching the tongue. Uh, so I think it's I find giving comfort to tongue makes an appliance just very easy to kind of get used to. We will take some questions and then I'll kind of continue before we talk about anatomy. Let's see if I have any questions so far. Okay. Do we have any questions?
Yeah. So the first one isn't really a question, but maybe you know what they're referring to. It just says bruxism versus clenching.
Okay. So bruxism is the gnashing, teeth to teeth, active gnashing versus clenching is where teeth to teeth and there's just sustained contractions. Okay. Most commonly, nighttime behavior tends to be more bruxism, but compared to daytime, people often clench. Uh, they're quite common, either one. And from a behavioral standpoint, daytime behavior, regardless of, typically tends to be more clenching, is easy to counteract, mainly because it's just easy to learn. I often tell patients a good analogy I tell them is if you are a right-handed and you are brushing with right hand, how long will it take you to brush with left hand? Okay, it will take you a while. Okay, so that's what you're trying to do. You're trying to almost reprogram some subconscious behavior, and brushing is a conscious behavior, while clenching is more a subconscious behavior. So it takes time, but not that long. Now, if it's a nighttime behavior, I say it takes 6 months. If somebody was going to stop it, 3 to 6 months rather than very quick. And my design stays the same. My appliance design is not dependent on the habit. It's really dependent on the symptom and maybe even the anatomy. Let's see if I can see if there's any questions.
All right. The next one is, what about a teenager that comes in post-ortho, still having pain and already wearing an Essex or Holly?
Great questions. So uh, 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 you can definitely modify an SX, okay? And at times, my first modification tends to be just fill up the crevices and the occlusal surfaces, make it a flat plane, and see. I often find a lot of SX have a slight shift. So if you are able to uh, kind of identify a shift, try to eliminate it, and typically by adding, not don't grind it out, because uh, I always find you want to kind of uh, add rather than grind it out. But at times, if you have an SX, and especially if you have a model and you have a suck down, you can just take the model, put the SX on the suck down machine, and just suck down another 1 millimeter hard appliance on top of it, and have the patient use it for like 4 6 weeks, and you could just they just come apart. So it's almost like a veneer you can kind of suck down on top of a SX. Holly could be modified with acrylic, so same thing. They're a little trickier with occlusal changes, so just be careful about modifying Holly.
All righty. Can you explain how a stabilization appliance helps muscle pain? Wouldn't a patient who is clenching just clench into that device and create the same muscle tension?
That's a great question. So, majority of people, and this has been studied, like people don't necessarily grind more with occlusal appliance. Okay, there's like sleep studies looking at it. So clenching is a subconscious behavior, okay, driven by your brain. It has almost nothing to do with your teeth, nothing to do with occlusion anatomy. These are just our guides to appliance design rather than mechanism. So if you put something between the teeth, you are definitely kind of now changing force vectors, okay? So if right now molars is where I'm generating the most forces. And if that contact goes from teeth to teeth, which is really a relation like this, going to a relation like this, because our appliance would be flat plane, it's just not easy to sustain some contractions. But there's definitely, I would say every year I have one or two patients where I go through like 4 or 5 appliance designs. And before I find something that's comfortable, they don't wake up clenching and grinding. So, but I think there's definitely more of that risk with soft appliances. I see other question. What bite
Okay.
do you use for stabilization appliance,
Yeah.
CR or usual bite? Uh, so I learned this from Barry Glassman. So I think you want to use a natural bite, okay? No CR, not even a usual bite. Any appliance you do is repositioning an appliance, repositioning the mandible. No matter what kind of appliance you do, it's going to reposition the mandible because the mandible is moving in a arc. So you are stopping it before it's touching the teeth, except like a disoccluding appliance. Uh, so that's one. I found great success in kind of the later 5, 10 years of my career where I never ask patient if it's comfortable. I make it a point to tell this to patients. I'm making an appliance to kind of stabilize the joint, but not for, this is not a functional appliance. This is a functional position that you're going to kind of do tasks in. This is a position where I think the muscles may be a little more comfortable, the joint is comfortable. It's a transitional position to retrain the area. And guess what? Most patients don't get hyper vigilant about, oh, it needs to contact here, because these patients are in pain. You ask them, oh, does it feel comfortable? They'll start thinking it needs to be comfortable. It's a big piece of plastic. It just needs to kind of really target the joint and muscles a certain way, and that's the goal. Uh, can you explain a bit about disoccluding appliance? So if you look at all the data for NTI, and I feel NTI disoccludes the maxilla and mandible a bit too aggressive, and I've seen side effects. But not having contact, is it a biobehavioral approach, or is it altering mechanism in the joint muscle, or a combination of all? I think it's a combination of all. So that's why you're having a lot of benefit. I'll take one more question. TMJ pain or limited range of motion after delivery of appliance of sleep apnea. So this could be just uh, it could be recruiting the mandible, but it could be too high of a vertical. There could be a few different other reasons too. If it's kind of allowing the muscles to tense up even more. So those are the 3 common things I can think of. I'll save the questions for others for later. I'll kind of recontinue my presentation and get back to questions. I do have my slides. Play. I think. Okay. So, so anatomy tends to be another kind of uh, criteria which I often use to design appliances. If it's a narrow arch, especially a narrow maxilla, I'll pick a narrow a mandibular appliance. If both arches are narrow, then often I ask the patient, do you think you'll tolerate an appliance on the bottom or top? And I have the lab have no coverage on palate, teeth, tongue area. And I've made appliances where it's literally ends at the occlusal surface, and there's like literally no wall on the lingual or palatal, and the lab will make kind of ball clasps, so you're still getting retention. Same applies for tori. You want to, again, if somebody has massive tori, you want to not have the appliance extend much in that area. I often reduce contacts, occlusal contacts in the area of tori. So uh, missing teeth, you want to make sure there's no undercuts, so just be careful. I tend to prefer mandibular appliance for class 3, while a maxillary appliance for class 2 patients. But again, if somebody has a very narrow maxilla, I may still do a mandibular appliance even if it's a class 3. Uh, if somebody has sleep, okay, Uh, if somebody has obstructive sleep apnea, I typically do urge them to use an FDA-approved design. If somebody has snoring, then a repositioning appliance, large tonsils, enlarged or swollen uvula. Again, repositioning appliance. Okay. Uh, if sorry, I'm talking about bruxism. I spoke. So typically, I do an appliance for bruxism if they've fractured chip teeth in the last 6, 12 months. They have fractured occlusal appliances. Uh, they have morning headaches. They have jaw pain. That's when I'm doing an appliance. And I often do upper and lower kind of flat plane. Here, these are cuspid guided. I couldn't find actually on True Functions website uh, a simple flat plane, even though I know they've made me appliances top and bottom, which are just plane to plane.
Yeah, we
Uh,
can
so
definitely just customize this or
yeah,
create just
I know
two
I have
flat
a,
planes.
yeah,
We have opposite the order upper and lower flat
yeah.
planes. Mhm.
So I've done that a number of times and they work great. So uh, at times you can even embed a wire in it and keep the wire close to the occlusal surface. You can measure how often do they wear it down. Okay. And when in doubt, I am a big fan of quick splints. It's a very easy thing to do, and they're great things to have. Uh, Often at times, if a patient is hesitant, if a patient has, say, 3, 4 years ago, I had a patient who had this severe ear pain, was in the emergency for like 3, 4 days. Uh, Everything was fine, and comes home, and he had not slept for like 15 days, and he was miserable. No jaw pain. After the ER, went to a neurologist, scheduled for a scan, and then the neurologist said, your muscles feel really tense. I want you to see a TMJ specialist. I see him, and I'm like, I examine him. Joints are good. Nothing here except that sharp ear pain. He's like, Doc, I cannot sleep. And I'm like, Steve, I don't know what's going on. I'm not able to duplicate the pain. I'm not sure if this is related to job symptoms. How about I make you a transitional mouth guard and you sleep with it and let's see how things go. He's like, okay. He uses this mouth quick splint. 10 days later, comes back. He's like, Doc, this is lifesaver. I haven't had pain one day. And this guy was on Toradol, didn't help. Muscle relaxants didn't help. He's actually a couple of days of gabapentin. No, I know it's not enough. Didn't help. He had oxycodone, didn't help. And then quick splint, boom, it helped. And then he was like, Doc, what should we do? I was like, I don't know if you need, if this is acute. He only had pain for like, I don't remember, it's been like 4 years. So I was like, I would do nothing. He's like, really? Not a mouth guard? I was like, because you have no pain. He's like, what if this breaks? I was like, it's going to break in a couple of days. So let's give it time. So he comes back after like a week. He's like, Doc, this broke. Can you make me a new one? I'm like, I can, but you don't have pain. He's like, it's just for my peace of mind. I was like, okay. I make him another quick splint and never heard from him. And about a year ago, I see a patient. He's like, Doc, Stephen M, his name. He's like, he is my kind of uh, rabbi. And this guy is a rabbi. And he said, you're the man. I'm like, all right. Uh, I was like, so he must be doing well. And day before yesterday, I had got an email, and this lady says, Stephen asked me to see you. He said you changed his life 4 years ago. That was all quick splint, one quick splint. I made him a second one. I don't think he used it. So uh, really, these appliances are very powerful, and a lot of times, if symptoms are better, I'm not kind of playing with the system. I'm letting it be. Uh, Thank you. I know we have a bunch of questions.
All right. Thank you. Continue to put those questions in the question box. I've seen a couple more pop up. We'll just wrap it up here in just a moment, but put those questions in and we'll address those in just a moment. Thank you so much, Dr. Chandwani. We always love having you. It's been a wonderful topic this evening. Thank you all for hanging out with us and spending the evening on the screen here. If you need any assistance with those appliances or would like to join us for our webinar next month, you can scan those QR codes. Next month, our webinar is specifically on 3 ways to use AI to get your patients, to get more patients and referrals. So we're going to focus kind of jumping into the more like practice management side of things. That one is Wednesday, April 30th. And we're also offering 20% off that flat plane stabilization splint. I knew Dr. Chandwani was going to bring that up in his lecture today. That's one of his favorites. So we wanted to offer a promo code through next Friday. If you order one of those, you can receive 20% off using that flat plane 20 code. We will be emailing you the recording of this webinar. So give us a few days to get it edited, but then look out in your email for the recording of this. And so you'll be able to go back and reference it if you have any questions. Thank you again, everyone, for joining us this evening. Dr. Chandwani, it's always so wonderful to have you.
We have a few questions.
Yep. So continue to put those questions in the question box. We'll address those now. And then again, keep us posted if there's any other topics you'd like us to cover or any other questions you may have.
All right. So next question is, do you wean the patient off the appliance if their symptoms improve? Uh, I often leave it to the patient. I often tell them, I'm not a big fan of you using the appliance every single night. I tell them, once your symptoms have been good for 3 to 4 months, you can wear it 4 or 5 nights a week and kind of calibrate accordingly. If the 2 days you don't wear it, if your symptoms go up, then you need an appliance. But if they don't, take a break. So Sunday, Wednesday, take a break. And second thing I tell them, if say they're not able to wean off, they're just dependent on it, see until the appliance breaks. Once it appliance chips or breaks or get lost, see if you need an appliance. So uh, I unfortunately I have a bunch of patients who are really dependent on it emotionally, and they can't sleep without it. So it is a very case by case basis. But typically, once the symptoms are improved, I let I tell patients you don't necessarily need it. Uh, for functional, and I often tell them this is more a functional problem rather than a dysfunctional problem. They're either kind of doing something less than optimally, and appliances are physical therapy kind of devices, which is kind of recalibrating, negating that. Would you please go over different designs and indications of when to use? I'll have my slides with you, so it's really you can have the slides which talks about different designs and when to use it, bruxism. So when in doubt, I use a stabilization appliance, so which doesn't shift, kind of reposition the mandible. Uh, and it's not increasing the vertical too much. And then if it doesn't work, you kind of think of the different designs. Now, if they have jaw locking for 6 weeks, I use a repositioning appliance, but otherwise, again, I'm using more often stabilization appliance. Uh, okay, that's an interesting question. If you're using multiple devices or design financially, how do you address the cost? I actually think of the cost as time. Okay. If the appliance design, okay, and I often tell this to patients, if they need, my consult fee tends to be around 350 to 375, 395 for a visit. Now, if they need like four visits, it's going to be close to 2000. If the symptoms are simple and it's literally 1 or 2 visits, it's probably going to be 950. So majority of times, depending on the complexity of the design, if it's something where I'm taking a bite, the appliance is going to be kind of made, uh, it's going to be mounted on an articulator, I'm charging close to like $2,000. But if it's something very simple, uh, I am taking impressions, sending it out to the lab. 1 or 2 appliances, I'm still charging like 950. So I decide my fees more to do with how much time, what's going to be my lab cost, but more of the time. And I charge for office visit. So I don't have free visits for the most part. If they're coming in for like 5 minutes, I'm not charging for an office visit. But if it's like a low complexity visit, I'm spending 20 minutes, I'm charging something. Uh, can you please explain your approach to patients with arthritic changes in the TM joint? Again, great question. If there's arthritic changes, okay, if it's the condyle morphology is flat, I'm not too worried. Okay, but actually, let's recap. If there's arthritic changes, but symptom-wise, they have more diffuse muscle pain, I'm not worried. If there's arthritic changes and the pain is really localized in the joint, I'm a little bit concerned. Is it inflammatory? Is it degenerative? Okay. Uh, I'm more worried if there's osteophytes, so the cortical margin is not intact. Then I'm a little worried. Maybe they need steroid injections, and the appliance design is more, again, doesn't increase the vertical, doesn't reposition, very forgiving kind of posterior contacts. Uh, but if it's just flattening, I'm not too worried about the arthritic changes. Uh, can you recap to when to use Mira? Mira is Tara. Can you tell me what is Mira? M-I-R-A? Oh,
Uh,
Trish. Sorry.
That's okay. It's actually the photo on your bruxism page.
Okay.
It's actually Dr. Mayor Patel's design with the custard guidance
Oh,
or
so
custard rice.
yeah. So this is this so it's a incisal kind of guided disoccluding appliance. So that's what it is. Uh, so uh, I tend to prefer more full contact rather than incisal guidance. Uh, I'm more of a fan of a group function than canine guidance, uh, mainly because I feel it's more forgiving to the muscles, joint. There's no data, one better versus the other. Uh, Typically, I use if somebody is fracturing teeth, joints, sorry, not fracturing teeth, or even fracturing prosthesis or an occlusal appliance, I usually use upper and lower together. If it's a young patient, a 18, 20-year-old patient, you really want to make sure teeth are not shifting. Using an upper lower appliance together will prevent individual teeth from shifting. Now, depending on your occlusal scheme, so if you do a repositioning appliance or a disoccluding appliance for 6 months, they can have bone remodeling and they can still have occlusal changes more at a little different level, at a bone level, rather than changes in the alveolar sockets. But so always be aware that the more context you have, the less likely that you'll have occlusal changes. Jeffrey has a question. What's the best way to decide on the thickness of the appliance and how much to open and record the bite? So if it's an internal derangement, that's an easy answer. You kind of take a bite. I usually uh, use thermoplastic material to capture something where the joint moves easier, and the least repositioning the better it is, and the least vertical opening. So I start with a tongue blade or a Q-tip and see if I can have smooth movement of the joint using those. If I'm able to use that and get a smooth movement, I hold that and just take a bite in that position. If not, then you add thickness, cotton rolls, so it's a little thicker vertical. So that's internal derangement. With regards to muscle disorders, uh, I don't necessarily tell the lab what thickness or to use. I usually do a very slight repositioning forward by like literally a millimeter. But there's no clear uh, I feel as if every patient, it's a different thickness. So I don't have a good answer to that. I'm sorry, Jeffrey. If a patient with unilateral subluxation without reduction and no pain, you still use a splint. I actually had a patient last week. No, I do not. If there's subluxation, so if somebody has subluxation, okay, an appliance may not help. Like if you have an appliance which is just increasing the vertical, it could help. But in my experience, a lot of subluxation appliances just don't work so well. If they have pain, yes, they would help. If they have disc displacement, it will help, but not condyle subluxation. So, excellent point, Alberto. Thank you. All right.
Okay, I think that is all the questions for this evening. If you have one quick remaining, go ahead and drop it in the box here. Thank you again, Dr. Chadwani.
Thank you,
We're
Trish.
so thankful for you to spend the evening with us. Thank you, everyone, for spending your time with us as well. We always love to have you on our webinars. So you see a lot of familiar faces every month, which is really exciting. Hopefully we'll see you maybe at the AAOP. Dr. Chadwani and Frank and I will all be there. So definitely stop by the booth and say hi to us. And Dr. Chadwani won't be there at the booth, but he'll be floating around. Yeah, you probably will be hanging out there. So again, thank you all. We hope you all have a wonderful evening. If you have any questions, I know you've all received an email from me at some point. Feel free to reach out if I can help you with anything. We'll be sending out the recording, like I said, early next week. And we look forward to seeing you on another webinar soon.
Thank you all.
Thank you.
Thanks, Trish.
Thank you. Have a good evening.
You too.